I'm going to present you 3 papers which are surgery in motion. It's part 1 acquisition, part 2 interpretation, and part 3 targeted biopsy. What urologist needs to know. So, these are my disclosures. I'm a non-paid medical advisor of SPL Medical, making the Ferrotron, the former called Combidex, the iron oxide particles, and Soteria Medical, who is producing the MR in-bore manipulator, or called robot. Now, whenever we look at a new technique, you should look at level of 1 evidence proof. And it has been a long time since we had, it took a long time before we had the evidence. Now we have 4 level of 1A evidence papers. The most important one is the Cochrane meta-analysis. They all make a statement that MRI should be done before biopsy, and I will show you the data. I will show you the data from the Cochrane meta-analysis, 43 Quadas 2 criteria paper with more than 5,000 patients. Our 4M study, which was one of the level 1A studies with 626 patients. And I would like to show you our expert experience beyond the 4M paper. At this time, we have been doing prospectively more than 3,000 patients. Now, you can see that in the Cochrane meta-analysis, no biopsy, that means a PIRATS 1 and 2, negative, is done in 33%, with a negative predictive value of 96. Negative predictive value is equal in the 4M study and in these patients. However, if you look at the recent data set, and this is the future for MRI, you can see that if we move more into a screening situation, the number of men that are negative on MRI will increase with a high negative predictive value. Now, in how many patients did we do biopsy where there was no prostate cancer? In 52% with the TRUS, in 21% with the Cochrane meta-analysis, and with expert MRI, 8%. Prostate cancer was found in 35% versus 48 and 46. So you would say this is good. And a lot of papers make the statement that TRUS biopsy is better than MRI in detecting tumors. And you've heard the previous speakers making statements like that. But you should look at the prostate cancers. Most importantly, how many significant and insignificant cancers do we detect? And here's the big difference. 25% with TRUS biopsy versus 17 and even 9% with MRI. So the overdiagnosis and overtreatment is reduced when using MRI. And there is no inferiority of MRI as compared to the detection of significant cancers. It's about equal. Slightly better, but no significant difference. Now, most importantly, and that's the reason that we think about moving towards transperineal biopsy, is the complication rate. The complication rate is 0.1 with MRI because you stick in only 2 or 3 needles per lesion versus 3% with TRUS biopsy. Cost effectiveness. MRI actually saves money because you save overtreatment and complications of biopsy. In my country, per patient, €500 is being saved. Now, because of these level of 1A evidence papers, and it took quite some time again, the EAU guidelines earlier this year have changed. In patients with prior negative biopsy, perform MRI before the biopsy. And also in patients who are biopsy naive. And just this week, the guidelines in our country have changed, the NICE guidelines in the UK have changed, the guidelines in Belgium, etc., etc. So Europe is moving into MRI in patients who have a risk for prostate cancer. Now, what is multiparametric MRI? It is not only T2. With only T2, you will not reach the top of the mountain. You need diffusion and contrast. So, T2 is showing anatomy, just like pathology. Biology is being shown by diffusion-weighted imaging, and vascularity, of course, by contrast. Now, this is anatomy. You can see that anatomy is very nicely displayed with MRI. But if you see a lesion like this, it can be either a BPH, it's dark, it can be prostatitis, hematoma, or cancer. The specificity of T2-weighted imaging is very poor. And you've seen in the previous presentations a poor positive predictive value, and I think that the use of diffusion-weighted imaging in performing biopsy, perhaps in those studies, could have been a little bit better, because we need diffusion. We need it. In Gleason 1 and 2, you have a very wide area in between the cells where the motion of water is very, very high. In high Gleason tumors, the cells are tightly packed and motion is reduced. So ADC, the apparent diffusion coefficient map, is showing water motion. Low is black, high is white. So when there is a black hole on ADC, it's bad. It's a 4 or 5 component. Vascularity is good, but also BPH and prostatitis and Gleason 3+3, so insignificant cancers, grade 1 cancers, do show enhancement. Now, in MRI, all steps needs to be correct. And this is important. Acquisition is being forgotten, and I will spend some time on that. Reading is important, and finally, of course, biopsy. Let's start with acquisition. Acquisition parameters are being shown in this paper, the PIRATS version 2.1. So technical description of what you should do. However, it's not just putting the parameters there and push a button. No, MRI is difficult and different. This is an MRI according to the PIRATS version 2 criteria, and this is an MRI. Here the diagnosis was made, 3 PIRATS 4 lesions in the transition zone. Now, if you have a high resolution, optimal MRI, you can see that there is a full delineation, demarcation of a capsule, which is a PIRATS 1. Here this patient would have needed at least 20 needles, and in this patient, follow-up is better. So, what was performed here was follow-up, and it showed a similar image. So this patient has BPH and no tumor. False positive due to a poor setting, poor handling of the patient. How you should do it is being described in the first paper of the European Urology. Now, do you like this image? Who likes this image? Is image quality okay? It's not bad, isn't it? Well, I don't like it. This is motion artifact. Repeat. My technician knows. So, she repeats and you can see a much better delineation. You could say this is erased charcoal, PIRATS 4 or 5, and this is a PIRATS 1. Just repeat the image. And I would like to show you what the problem is with MRI. This is the dancing prostate. You can see how the prostate moves due to air in the rectum. You laugh, but this is a serious problem. If the patient evacuates some air during the MR examination, which is possible, you have a moving prostate. Rectal gas, another terrible thing. I hate it. My wife hates it as well. If you have rectal air in the, like this, you see that the diffusion-weighted image is crap. Terrible. How to improve? Okay. By putting in a urinary catheter, remove the air. This is from a French colleague, François Conny. He sucks out the air. So the air is being removed, and you have now a nice image versus a terrible image. You also can give a small enema. Magnetic field strength, 3 Tesla is preferred, but the previous speakers have addressed to the negative things of MRI is that you can have a pacemaker. Well, most pacemakers are possible to be in the MRI. It's not the Tesla which is important, it's the gradients which is important. You can have poor 3 Tesla machines with poor gradients and good 1.5 Tesla machines. If I ask you which one is 1.5 and which is 3, you can't tell. Well, This is 1.5, this is 3. Equal good gradients. Now coils, to coil or not to coil, it is the question. I don't like it because it gives motion and other artifacts. And it is actually in 1/3 of the patients worse with an MR coil. So without coil, with modern machines, the images are good enough. Contrast. To DCE or not to DCE? That is the question. Okay, when you want a nice discussion for 4 hours, ask 2 radiologists to discuss about DCE. Well, this is a paper showing that you can do 2 patients per hour with contrast, and without contrast, 3 patients per hour. Results are equal. Okay, good. No contrast in your brain. That's even better. But you need expertise. Otherwise, this will happen. The PIRATS 3, this is the prostate radiologist bucket. The I do not know increases an expert's hand from 6 to 8%. Well, this is not bad. But if you have a not so good radiologist with a bucket of 25%, it increases to 33%. So he needs contrast. Good. So DCE helps to find the tumor. DCE is reducing uncertainty and is especially helpful in less experienced radiologists. Conclusion, it should be used. Reading. Okay, this is the interpretation. We need to speak one language, and that's what we do as radiologists. We speak PIRATS. That's good. In 2012 we started. We have an update in 2015. We'll have an update in a few years. So this is a continuing story. It has already been shown 1 and 2, cancer highly unlikely or unlikely, and 4 and 5, clinically significant cancer is likely. So you assign a lesion with the 3 components in the likelihood that there is, you give an overall score for the presence of a clinically significant cancer. What is clinically significant? Again, a nice discussion. Just to summarize, it includes a 3+4 with a prominent but not predominant Gleason 4 component. That's what we see with MRI. Okay. Now, we use different weighting. I'm not going to in detail and give you an MRI course. That's perhaps for another time. In the peripheral zone, the black holes are important. Diffusion. In the transition zone, anatomy is important, so not the black holes. That's what you should remember. And contrast is plays a minor role. PIRATS is KISS. We kept it simple and stupid. It is a simple way, but it works. Simple algorithms to determine the overall score. You can read it in the papers. 42 peripheral zone, 42 transition zone, 4 diffusion for both, etc. I would like to show you a case. 70 years, PSA 9.8, T0, and his prostate was 115 cc, and he had an elevated PSA, as you see. This is the T2 weighted image, axial, diffusion, and contrast. And what we see is that we can calculate the volume of the prostate. It was 115 cc, so it's a big prostate. Axial T2, you can see it. You can see it on the sagittal T2 over here. And there's even a hypertrophy of the medial lobe, so this patient may have some urinary symptoms, compressing the urethra. The coronal image also showing a big prostate. And this is organized chaos. Black and white dots, good demarcation. For the diagnosis, we actually are looking now at the diffusion-weighted images. This is the B1400 and the ADC. The B1400 shows a small lesion of a compressed peripheral zone, which is white. So, I will put a circle on it. This is a white lesion. Now, this lesion cannot be seen on the corresponding other diffusion-weighted images. You have 2 images, the bright image and the black image. This is the ADC. And this is white, but not focal black. Okay. So white and not focal black. This gives a score of 3 for diffusion. And as this is the dominant sequence in the peripheral zone, the PIRATS score would be 3. So, not here, not there. Focal wide, that's good. So, PIRAT 3. Now, in PIRAT 3, there is a referee. The referee is called DCE, so contrast is very important. So let's have a look on contrast. It's this image over here. So we're looking at this lesion on this image. You just page through the slices, and you see no enhancement in the rest of the prostate, and early enhancement here of this lesion. This is bad. This is what we call a plus. So a tiny lesion. And I put this patient on Twitter. It was missed by the expert radiologist in 40% and urologist. So it is a quite difficult lesion. With a plus, a 3 becomes a 4. So this becomes a significant lesion. Let's now look at the anatomy. Can we see it? Yes, it is compressed. It's over here. It's tiny. Tiny, focal, on structure images. And you can see it also, if you look closely on the coronal image, it's over there. It is peripheral zone. So you can actually draw a line, and we can just contour the lesions for fusion biopsy. I think this is a role for the radiologist, and we should be able to give you a contoured, DICOM-compatible 3D information where the tumor is located. Of course, this is an easy tumor for biopsy, peripheral zone, and it's over there. Now, the next step we need to do is to measure the lesion. If it's larger than 1.5 centimeters, it's a PIRAT 5. If it's small, you will see the measurement on the dominant sequence first. It's about 5 millimeters, and here it's about 3.4, so it's 3, and CC on the anatomy. So the lesion size is 5 by 3 by 9, which gives a PIRAT 4. So the actual score of this focal lesion is 4 on T2, 3 on diffusion, black and not white, and plus on contrast, this is 4. And the 4 needs to have a biopsy. Patient preferred a transperineal biopsy, and that was done under MR truss fusion, and you will see the results in a few seconds. He was right. It showed a Gleason Score 4+4 lesion. And you can predict it because it enhanced, and that's important. Does MRI miss significant cancer? The big question. Well, the answer is yes, we are not perfect. It's in between 2 to 11%. So an answer to one of the questions which was asked to you earlier. In 1945, you did feel a heart lump, and in 2014, 60 years later, we see the heart lump. So we see the heart lump on diffusion. But the serous tumors, the mucinous tumors, we will miss because they mimic prostate cancer. The ones we miss most is the large 3+3, and you can ask yourself, are they significant? And 3+4s. In our 4M study, 90% of the missed tumors were 3+4. So, yes, we do miss tumors. And the thing is, this is a 3+4, and this is a 3+4. We are likely to miss this tumor because it's only 1%. And we see only the 4 components. I will show an image later. So, we don't see this. I think we are going to recognize this when there is 25% of Gleason 4. Unfortunately, most pathologists are not predicting and showing in their report the 4 components. Perhaps with artificial intelligence this will improve. Now here you see a tumor on a patient with an elevated PSA, 4 times negative thrust biopsy, a black hole on ADC, in the peripheral zone, a bad guy. So MR-guided biopsy 4+3, prostatectomy, large tumor. Okay, many papers show a not correct correlation between tumor volume and MRI. What's wrong? Well, if you look closely, this is Gleason 4 with a center of, Gleason 3 with a center of 4. And we only see on these images the 4 components. So that's another take-home message. Targeted biopsy. Previous speakers already have shown that you need to have experience, otherwise your results with MR and MR-targeted biopsy is not good. It is probably at this moment the weakest part of the chain. So most bad results are actually caused by non-optimal needles. And to learn it is not easy. In Pocconi, the false negatives on MRI were sampling errors in 67%. So, which technique should we use? In-bore, fusion, or cognitive? Let's have just a slight look at literature. In-bore and fusion biopsy have a better overall prostate cancer detection with cognitive biopsy. Wegelin in 2016. And the detection rates of in-bore and fusion are equal. Arsov. However, if you look at the lesions that we see on MRI, and the previous speaker already has said that, when you know where the lesion is, and you go back to ultrasound, you can recognize it. More than half of the lesions detected on MRI were in retrospect visible on truss. That's good. So you can do cognitive biopsy. And for Pirates 5, the bad guys, this is in almost 2/3. So, truss-visible lesions also tend to be more aggressive than truss-invisible lesions. And more than half of the visible lesions contain a major Gleason 4 component. So, this is good. This is a black guy on ADC with some enhancement, and you can see something here. So this is the lesion. Now, if you look at ultrasound, it's over there. It's easy. Stick in a needle. That's what happened. You can see the needle over here, and it was a Gleason 4+3. So, MR-guided biopsy is not easy, and it's prone to sampling errors. So we need to do increased sampling to reduce this, especially in the learning phase. When you start to do this technique, better take 1 or 2 or 3 cores more than when you are experienced. It will increase the number of clinically significant cancers. So, if you start, even with in-bore biopsy, at least 4 cores per lesion. So it's not easy. It's prone to sampling errors, and experience matters. That's the most important thing. And this is the area where radiologists and urologists should collaborate. The MR-guided biopsy technique, whether we do it in-bore, with fusion or transperineal, is being decided in a multidisciplinary team. All the experts are there. So we discuss it, and then we do it. What are the challenges of MRI? Is everything nice? No, there are challenges. This is the tsunami. If the guidelines change, in the United States, the radiologist needs to perform 1 million prostates every year, because those are the patients who have a risk for prostate cancer. Tsunami. So I warn the radiologists, but they keep swimming in the sea. 0.5% of all men need an MRI. Okay, well, we should be ready. This is what I frequently hear. Yeah, Jelle, you can do it, but your colleague next door, he can't do it. And you're right. You're damn right. You can see that there is a variability, 56 to 97% in the negative predictive value. I'd rather not go to a radiologist who has a negative predictive value of 56%. I'd rather go to this guy. So the most important thing, you know in a report what the most important thing is? The name of the radiologist. Because then you know how good the report is. So we need to do things. And the things is training. So we have been starting to do training. Very popular courses. Now, we also give courses for urologists because it's just like CT. When we had the IVU and then when CT came, radiologists said this is very complicated and urologists said this is terrible. But now you all can read HCT of the kidney with a kidney tumor and of the pelvis. So you should learn black holes, white holes, contrast areas, T2, diffusion, etc. And we should perform quality control. We have now recently finished a Delphi analysis which will soon be submitted to European Radiology, and I'll give you a glimpse of what the experts of urology and radiology said in the Delphi analysis. 2 rounds of Delphi analysis on image quality assessment, on interpretation and reporting, and the center itself. So number 1, this is what radiologists do not do. They should report their quality in, well, they should report it. If they don't do it, ask them, how is the quality of your MRI? Second, Checking image quality, this improves MR reproducibility. A good image is easy to make a diagnosis. In a poor image, even the expert has a problem. So I ask my technicians, whenever you recognize a poor image, and I train them how to recognize it, they repeat the sequence. We need to develop qualitative and quantitative criteria, and we have already a few of them, and we are going to implement it. We need to have objective quality control with a 6-month interval, or every 300 to 400 cases. So you need to have a view as a radiologist, is my quality going good? Is it good, or is it getting worse? Quality control of randomly selected samples needs to be done by a quality institution, American College of Radiology, for example. And we need to develop a phantom for DWI for ADC, because the ADC value from machine to machine is not that much variable, but a little bit variable, and we should exclude the variability. 2, what about the radiologist? Self-performance tests need to be done with histology feedback every year. You need to do an external internet-based performance assessment. Double read with expert reading and supervision when you start. Institution-based audits should be performed, just like breast imaging. What about PIRATS 3 as a quality criterion? There was no consensus because the participants thought that the prevalence of cancer plays also a role. Yes, however, there are a few papers which say, okay, specialists have a bucket diagnosis, I do not know, of 6% versus 28% of the non-experts. So whenever you want to test the quality of your radiologist, ask him, how many PIRATS 3s did you score this year? Okay. If it's above 15%, perhaps you should give a call and say to him, hey, is something wrong with you? So, attend the course before reading prostate MRI. Yes, it seemed logical, but this is the advice. You need to go to an extensive hands-on 4-day course. Double read cases, more than 100, because they did not learn prostate radiology in their training yet. The total number was 300. Well, you can disagree. Other people say you need to read at least 500 MRs before you can call yourself a basic radiologist. Now, if you give a 4-day hands-on course with 100 double reads, you can see that your kappa, your agreement, increases. But these were high-quality images. So this is what we can do. Now, just have a look at these data. 100 cases, 300 cases, 1,000 cases. And you can see that the area under the core curve improves. So, perhaps we should read 1,000 cases. Also with biparametric MRI, you can see with biparametric MRI that a poor radiologist with the true positives and the sensitivity as well as the area under the curve, that he is not good at all. Okay, read at least 150 cases a year, examination every year with 80% agreement of the expert diagnosis. Expert. 1,000 cases, some people say 2,000 cases, read at least 500 cases a year, examination every 4 years, with agreement with your colleagues of 90%. Well, DRE for radiologists. This is the warning finger. You will give them a DRE if they don't perform well. That's your task. What does it mean? It doesn't mean DRE in your sense of what you think it is. It is develop radiological expertise. Give them a DRE, the finger. So, stimulate radiologist, this guy, to be certified. This patient is laughing, but he doesn't know whether he's certified or not. Okay, give him a DRE. Yes, and don't forget, learn PIRATS yourself. It's easy, it's fun, and it's necessary. Thank you very much for your attention.